Okay, so this is a presentation. We're going to look at the holistic view of cardiovascular disease by Michelle Lanham. So cardiovascular disease is the leading cause of mortality in the U.S. The CDC claims that 1 in 4 deaths are actually caused by heart disease in the United States. This disease is not only deadly, but it's avoidable through biopsychosocial pathways. There are several pathways that disease can enter, and I do want to discuss the etiology and factors that relate to heart disease. And we're going to discuss some research, because there's plenty of research looking at those biopsychosocial factors that are correlated and looking towards better outcomes in prevention programs, rehabilitation programs, and finding ways to lower those mortality rates. So the pathophysiology and etiology of coronary heart disease. We do know that lipids accumulate and travel throughout the bloodstream. When these lipids gather and collect, there is a waxy plaque that forms along the inside of the arterial walls. This becomes a disease event and is known as atherosclerosis, which atherosclerosis impedes the flow of blood through those vessels, depriving the heart of blood ultimately, and possibly resulting in heart attack or mortality. So the known risk factors, there are many, and predictors of heart disease. Many are commonly known and commonly discussed by practitioners. When you talk about heart disease, they'll mention blood pressure, cholesterol, poor diet, obesity, smoking. However, there are several factors on this list that do get less attention, and they're in relation to the negative emotions like stress and anger, things like low life satisfaction, low social support, and low spirituality. So there's lots of research to support the need for attention on these biopsychosocial factors. These authors here designed a study to validate a model that predicts coronary heart disease by measuring variables such as family history, biopsychosocial health, lifestyle behaviors, age, work, non-work, social variables, and gender. These authors used measures to assess the risk of coronary heart disease that included systolic and diastolic blood pressure, high-density and low-density lipoprotein panels, triglycerides, fasting glucose, and obesity. The findings of this study looked at job characteristics and found that those, along with non-work social ties, were indicators of biopsychosocial health. However, biopsychosocial health was also correlated positively with healthy lifestyle, and healthy lifestyle was found to be related with lower CHD risk. So the more support, the more happy people are with their job, the healthier lifestyle they lead, the lower risk they have. On the other side of that, they did find that higher coronary heart disease risk was found to be predicted by family history. If they had heart disease or stroke in their history, gender wasn't an issue, but the more risk factors that cluster, the higher risk of heart disease was found. we have Motivala discusses correlations that have been found connecting sleep and inflammation to cardiovascular disease and to mortality from disease. Because inflammation affects these pathways through the immune system, chronic inflammation does do long-term damage by activating and elevating C-reactive protein, interleukin-6, and inflammatory cytokines. Inflammation that is chronic activates adhesion molecules as well, which do create an entry to the vessel, and once the plaque forms there, the vessel weakens, as discussed by Harlepour, Abraham, and Shimbo. So once this weakening happens due to inflammation, the cap that encloses the plaque and the vessel eventually gives. This causes a rupture and further impedes the flow of blood. This rupture is known as thrombosis. The blood then begins to form clots to repair the damage, furthering risk to disease and even mortality. So, authors also found that length and quality of sleep is correlated with heart health and mortality. Poor sleep is correlated with obesity, smoking, inflammation, and alcohol, which elevates the risk of cardiovascular disease. They also found that smoking does raise a higher risk for CVD than lung cancer. And when depression is combined with smoking, it's possible that the individual will smoke more, and smoking more will stimulate further depression, ultimately leaving them with increased negative effect on the heart's health. They also look at diet and high-low density cholesterol. Kromhout and Blomberg discussed the correlation of raised low-density lipoproteins from saturated fatty acids found in poor diets with ischemic heart disease, and also lowering these foods will aid in the recovery from and the regression of coronary sclerosis. We're going to look more into these biopsychosocial pathways and at some of the research that also supports it. These authors did study health outcomes from cardiovascular disease patients that were in two different types of rehabilitation programs for their disease. The first is a typical rehabilitation program referred to patients by their cardiologists. It is a self-reported cardiac rehabilitation assessment. It's a standard program, and it encourages the patient to collect data regarding their health, lipid to include lipid panels, nutritional education, as well as take some exercise courses. The program is well established, but it does not address any biopsychosocial factors. The other assessment that they used in this study was the lifestyle change program. This one is not well established just yet, but it does address those biopsychosocial factors. And they offer stress management, group support, monitored exercise, cooking classes, nutritional classes, educational lectures, even music therapy and spirituality courses. These are all offered in hopes to cover all the facets of a healthy lifestyle. The findings of this study, the study ran for about 3 months, and authors did compare mental and physical status at the baseline as well as the completion of the program among the two groups. They use scales and measures to collect data regarding hostility, depression, social support, stress, life satisfaction, spirituality, and their lipid panels. The initial mental and physical health status of the two groups were similar. However, both groups did show improvement after using both programs. This tells us that any intervention can positively affect those with coronary heart disease in these areas. But the significant differences were found among the biopsychosocial ones. The lifestyle change program participants did report improvements in stress levels, lipid levels, depression, life satisfaction, and spirituality. This does indicate that this holistic approach could better help reduce the chance of future cardiac events. This author also discusses that there's an emerging desire for recovering heart patients to receive more holistic approaches to care and treatment. Less than 20% of them ever even get these types of referrals, however. The author goes on to assert that due to much supportive research, the application of the biopsychosocial approach is vital to the maintenance and control of heart disease, and addressing the psychosocial factors in interventions for cardiac patients has been shown to prove self-confidence, vigor, and medication compliancy. This author actually does discuss that since the patients are not getting enough of these interventions, the author does counsel both heart patients and physicians, and also here's not only the desire from the patients to receive care, but here's the physician's worry that they are not well enough prepared and have too little time to provide the adequate care the patients are requiring. As resources are limited, it would take a whole team of nutritionists, exercise physiologists, physicians, nurses, mental health providers, and possibly more to address all the needs of a recovering patient. So this proves that resources are an obstacle that needs to be navigated. Additionally, the author mentions that the two cohorts that are often looked over the most for their rehab referrals are women and elderly, as most referrals offered are to men and younger, healthier patients. So this, again, lets us know that we need to address demographic groups to reach all types of people. Another study studied these factors that actually prevent women from participating in community-based interventions for cardiovascular disease. They followed and employed a grassroots organization known as Sister to Sister, who is affiliated with the Women's Heart Health Foundation, and had them provide data. They did approach 9,443 women. Only 559 women participated in the program. Participation in the program meant they completed a questionnaire, a cardiometabolic risk factor measurement, as well as a physical screening and some individualized counseling. They could participate to be observed for up to a year, with interviews between 6 and 12 months after intervention. What they did find is that the majority of the women who participated in the long term, between 6 and 12 months, were white, slightly older in age, and had health insurance and income levels of $75,000 or more per year. They were also more likely to have hypertension and metabolic syndrome, elevated LDL cholesterol, and obesity. This does indicate, again, a need for demographic and socioeconomic factors to be considered when designing these types of intervention programs so we can address multiple groups of people. These authors actually assert that negative emotions are bidirectional. This indicates illness causes negative emotions, and negative emotions can cause illness since they are correlated with the dysregulation of the immune system through heightened production of pro-inflammatory cytokines. The negative emotions generally are things like anger, hostility, anxiety, stress. So in more detail, we're going to look at anger and hostility, which were correlated with higher waist-to-hip ratios and poor high-density lipoproteins, which is the good cholesterol ratios. Also, increased smoking and alcohol use in those who experience more anger or hostility. As far as anxiety, anxiety has a relationship with CHD on the development of acute and morbid coronary heart disease, as well as reoccurrence of coronary heart disease. So all these negative emotions contribute to the development of heart disease through the stimulation of the autonomic nervous system, as well as through activation of the hypothalamic pituitary adrenal glands. Here we're going to discuss these authors who talk about the autonomic nervous system and how it responds to stress and restricts blood flow by vasoconstriction. Those who do experience these negative psychological states while battling heart disease have a higher mortality rate. And any cluster of biopsychosocial factors that are present in one individual will raise the CVD occurrence rate. The authors did study the heart rate variability among those with and those without cardiovascular disease. They did measure the heart rate variability responses to mental stress tests and physical stress tests. The participants were given surveys to measure their depression, vital exhaustion, impulsivity, and adventure levels, as well as attention span. Participants with coronary heart disease scored higher on every scale than the control group. They also showed fluctuation and rise in heart rate variability more than those without cardiovascular disease during mental stress tests. So results of this study actually highlight the need for further research to find suitable psychological interventions, such as relaxation or therapy for the recovery of cardiovascular disease. Meditation, several different options there to look at. Harper, Abraham, and Shimbo, again, they discuss the lifestyle changes that are recommended to cardiovascular disease patients. The recommended changes include 30 to 60 minutes a day of exercise, a healthy balanced diet with attention to saturated fats as they are linked with atherosclerosis and smoking, the intake of good fats such as omega-3s, which is found in fish or avocados. These have been found to reduce the risk of heart disease. Social support is linked with the ongoing success of disease prevention, and fostering a relationship and an open communication between patient and healthcare provider actually promotes accountability and further success to enjoy a healthy heart. So we can see there's many biopsychosocial risk factors related to cardiovascular disease. Many are avoidable. Many people can avoid this disease with lifestyle changes and proper care and monitoring. There are interventions and programs and social support that are needed to help educate, prevent, and or recover from disease. Education seems to be, and intervention seems to be the most effective way to help prevent, help treat, and recover and prevent further occurrence among those who are at risk of heart disease or who suffer from heart disease. So looking into these pathways and further research can definitely open up doors so that people can keep calm and live a healthy life.